Selena. This is really a great opportunity to chat with all of you and to present a little about what we know about this disease. So thank you everyone for coming. So today we're going to talk about what's called the neuroendocrine mixed acinar neuroendocrine carcinoma of the pancreas. So what's the mixed acinar neuroendocrine carcinoma? Many patients may face this disease, or they have a relative who have this disease and they don't know what to do. And also for clinician, it's kind of a very rare disease. So it's kind of like we still don't know a lot about this disease, and the picture is not clear yet. So I have nothing to disclose, but I should mention that although I finished my medical school back home in Sudan, I'm not a practicing physician yet here in the United States. So I cannot describe or prescribe any treatment for any patient, but I'm working with a wonderful, great team of medical oncologists, surgical oncologists who helped me to reach this level. So I'm more than happy to refer them any treatment question for my mentors. So I have objective for this talk today. So I'm going to give a brief information about what we know about this disease, and then I'm going to talk about the questions that I'm looking for through my research to answer, and then I'm going to jump into a few potential future direction that could help the patient first. So I'll start with the information. So as you know, this disease is mainly affecting the hepatobiliary at the pancreatic region. And the one that I'm focusing on is only affecting the pancreas, but it could be metastasized to other GI tract organs as well. So I was really lucky working under Dr. Mark Trudy. He's a surgical oncologist here, and he had one of the biggest laboratory focusing on implanting tumor into mice to develop models that could help the clinician to answer related questions. So while I'm working with him in the lab, we can generate tumor from the patient into the mice, and if they grow, we call them avatars, and they actually look characteristically similar to the patient tumor. And this is maybe a good point where I can tell a story about how I've been involved with this rare disease. So I remember in 2018 when I joined the lab, while we were working on the mice, we were just being called about a mouse that has a very big tumor. And we go directly to that mouse and we take the tumor out. And when we send it, it's to the pathologist, it's actually came with this diagnosis. So I just went to, as everyone may do, is like to the Google. I start searching about what's the mixed acinar neuroendocrine carcinoma of the pancreas, and I couldn't find a lot. So I was like in the beginning of my journey doing the master here at Mayo Clinic, and then I remember I went to Dr. Trudy and just say to him like, hey, wouldn't this be a great opportunity for me to dive deep maybe on this disease and trying to find something? And he was generous enough to support me through my journey. So this is how I become involved from what I'm doing here. But other things that we can use when we do those animal models, we can understand the genetic information about these disease, and also we can test some drugs on those mice, which has been very nice. And we're trying in the future maybe to direct the therapy or develop like clinical trials to help those patients. So as I mentioned, like this disease is mainly about the pancreas, and we'll just stop a minute here to look into the population who of the cells who's like involved in the pancreas. It's a big organ with a very heterogeneous cellular population. So it has what's called acinar cells, which is actually produce like the pancreatic enzymatic juices that's go into the digestive tract and help with the digestion. And then there's the ductal cells, which is being like kind of a bridge to the GI tract. And then there's the neuroendocrine cells, which is involved in the producing hormones that could control many of the body function, importantly, the blood glucose level in the body. So jumping from that to the pancreatic cancer overall, it's one of the deadliest cancer in the world, and the 5-year overall survival relative to this disease is very poor. And actually, it's been projected by 2030 to be the second cause of the cancer-related death in the United States. So it's very worse. But when people talk about pancreatic cancer, they mainly talk about the first subtype, which we called pancreatic ductal adenocarcinoma. And it's composed around like 80% to 85% of the all pancreatic cancer, and it's one of the main one that's been studied a lot. And it's one of the worst. And then that will be followed by the pancreatic neuroendocrine tumors and pancreatic neuroendocrine carcinoma in the second bucket here, and it's composed about like less than 10%. And then there is a very rare tumor called the pancreatic Acinar, cell carcinoma, which is composed around 1%, but that's left very, very small amount to other type of pancreatic tumor or pancreatic cancers. Within that bucket, there is what's called the mixed Acinar neuroendocrine carcinoma, or we'll call it manic P for short. So how that's look actually in the tissue, it's actually a composition of both population who's living together. So you will find like this will be defined by the WHO at least to be composed of 25% of acinar carcinoma, and then also a 25% of a neuroendocrine carcinoma. They're living together, but it's not only that. It's very fascinating that there is some cells within that tumor actually where it looks similar to the both population. So it has some markers from the acinar cells and some marker from the neuroendocrine cells, and scientifically it's called amphicrine cells, and it's one of the very fascinating cells to be found in this tumor. That's make it a very unique tumor. So I think that's one of the reasons that we need to study this tumor more in depth, because up to date, we don't know who is the main driver of this tumor. Is it like they are just growing together, the acinar and the neuroendocrine cells, or maybe this cellular population who had both markers that actually driving this tumor? So that's also captured my attention to dive deep into this disease. Now, when it has been firstly reported in the literature, that's go back actually to the 1980s, whereas one case has been reported from University of California, Los Angeles campus with Dr. Klaus Lewin, who reported the first case from the United States, but that has been actually, there is one case that has been reported few years before that from Japan. It's actually a child or a teenager who had developed this disease, and it has been reported as a case report from Kyoto University. So, and then I look back to the older literature, and it looks very similar. It's actually a lot of case reports that has been reported about this disease. So you cannot find like a big series about this disease. Most of the literature is just case report. I think one of the biggest literature that has been reported came from the John Hopkins, where they use the American College of Surgeons quality databases, and they look to the differences. And from that, they actually reported that the 5-year relative survival for this tumor is a 37%. But this study couldn't answer all the question about the mixed acinar neuroendocrine component due to the inherited limitation of that databases, which cannot like tell, for example, what we call the cancer-specific survival related death. So the death related to this cancer specifically. And that's why there is a very gap in the knowledge to know the basis of this tumor, but also at least to know the distribution of this disease in the world, and also specifically here in the United States. So those patients who actually living with manic P, they are living through the uncertainty of the unknown. They are like living in very high distress because of the misdiagnosis. So some of the patient may be misdiagnosed in the first place, and when they seek a second opinion, they found about that they have this rare type of the tumor where they cannot find any information about. Second, there is no standard of care therapy for this tumor. So most of the oncologists, they would rely on some information from the case report, but also actually they may try to see who's the dominant cellular component in the tumor on the histology, and then try to treat according to that. So if they found more Acinar, they may treat with some of the standard of care therapy for the Acinar cell carcinoma, and vice versa. Also, the cost of looking for second opinion is very costly for those patients, and it has also very poor prognosis, as I just reported from the previous study from Hopkins. And actually, there is no in-depth epidemiology data about this disease. We don't know what's the impact of chemotherapy, and we don't know what's the impact of surgery as well. So there is a lot to be studied about this disease to help this patient, and I think we are just very early on this journey. So I will dive deep into more objective and the questions that I have been trying to answer during my study of this disease. So as I mentioned, I just did my master degree here, and my master was like kind of a holistic approach to build a strong foundation for future research on manic B. First, we aim to study the epidemiology of the disease in the United States, and then we'll look also to the impact of surgery on the survival for those patients. But not only that, I have like my second aim was to focus and characterize in depth the molecular basis of this disease and trying to understand from where it's coming and how it's behaving, so we can find some target maybe that we can treat with. And then leveraging what I have found in the lab here, the mouse model that we have, to use it as a screening model to try multiple therapies and see which one of them may be more effective on those tumor. However, will be a lot for today. So today I will just only focus on the first aim, which is including the epidemiology and the impact of surgery on those patients. So I'll start with the epidemiology. And for the epidemiology, I will only focus on the epidemiology of the United States. That's what at that time I have a readily available data to be used. So my aim was to try to estimate the incidence, which is the new cases that have been reported about this disease in the United States, then to look into the prevalence, it's the amount of the patient or the number of the patient who's living with this disease in the United States right now, and then look to specifically the cancer-specific survival for patients who diagnosed with manic B in the United States. For that, I used a database called Surveillance Epidemiology and End Result Databases, which is also linked with the National Program of Cancer Registry. And this database is actually very nice because they are combined, they cover, I think, most of the United States. So in regard to the incidence, which is the new number of cases, I will be able to report the incidence throughout the state of the United States. And then for the prevalence and the cancer-specific survival, I'll be also only using the SEER database, and that will be a less number of patients. So for that study, actually, the database of SEERS, it's been started in 1975 or 1976. And I went back to that year trying to find every patient who have been diagnosed with this disease, but I only could found 3 patients have been reported since 75 to 2001. So those 3 patients have been excluded, and then the cases have started to raise starting from 2001 till 2018. So I focus only on the years between 2001 and 2017. So looking into that database, I found the total number of manic B cases was 630 patients. That's what I could find in the database. And you could see this is a very low number for the large duration of time that have been covered through this study. And if we look to the incidence rate of the incidence of new cases that have been reported every year, it's about 1 case per 10 million. And you can see it's a very, very rare disease using this statistics. Now, although the incidence is a little bit higher on males compared to females, but it's quite similar clinically from the number that you see, but it's a little bit higher on males. Then I look into the distribution of the new cases across the age of the population. And you can see that the incidence will start to increase with the increase of age. And then it will reach a peak here between the age of 75 and age of 79 as well. And this is quite a little bit later from the peak for the pancreatic ductal adenocarcinoma, which is the most common pancreatic cancer type, which peak a little bit earlier than this. And that's maybe related to the diagnostic, and also which we know about a lot about the diagnostic that we can use for the PDAC, but most of the time it is very challenging to diagnose the manic P, because you need to be a little bit vigilant about using the right diagnostic to get to this and high suspicious rate. So it's a little bit a late peak for this patient with manic P, but then they will start declining after that, and that's maybe related to the age-related death. So it's quite similar to the distribution of cancer across age for other cancer, but it will peak later a little bit, maybe to the challenging in diagnosis. And then on the same thing, on the same figure with the distribution of age, we separate them. So the blue represent the males, and then the red represent the female. And you can appreciate that the incidence is a little bit higher in males than females. And it's actually significantly different between those two age group at 65, 69, and then at the peak time. Then I look into the distribution of the new cases that have been reported throughout the years. And you can see that the curve is actually start to increase to reach a peak at 2010, and then start to decrease a little bit. And when we look to the rate, that's the difference in the rate or the number of new cases before 2010 and after 2010, we actually found that it's a statistically significant difference. So there is an increase in the rate before 2010 and then slight decrease after that. But this is a magnified picture for only the manic P tumor. And it's actually quite funny when I show this to one of my mentors. He say, like, maybe you are studying a disease that's actually gonna disappear in a few years, so you'll not find anything to study. But I think the disease is still here. And we can tease that out if we actually make a comparative assessment with all other type of pancreatic cancers. So here's a comparative incidence throughout the years with some of the most common type of pancreatic cancer. Here's the adenosquamous or the adenocarcinoma, which is quite high incidence rate. And then here are some other types. But when we compare this to the manic, you can see here's the manic, which is the less, but it's still there. So it's one of the lowest new cases number for pancreatic cancer. That's in regard to the incidence in relationship with the number of with the years. Now we look to, after that, we look to the distribution in the disease throughout the United States. And for that, we were very lucky using this databases. So the darker the color, the highest new cases number. And then the lighter the color here is the lowest cases number. And you can see that it's apart from Nevada, which has the highest number of new cases, the cases has been distributed through like California, Texas, Florida, and then New York here as well. And then when we plug the actual patient number throughout the years, you can see it's actually true for all these states. And then Nevada has the lowest number, but the highest incidence. And this is related to the population in the Nevada. So the Nevada population is quite lower compared to the other state, and that's you have a denominator low, that will increase your incidence or the number of the new cases. But still it has quite few number of cases in Nevada, and that's maybe related to the population age at that state. But coming back to the other state that we found the highest number, California, Texas, Florida, and New York, this is maybe related to, we don't know the actual answer yet, but this is maybe related to that the patient move to a bigger cancer center to find some answers. And then that diagnosis would be reported from those big cancer center in California, Texas, Florida, and New York as well. So that's maybe one factor for that. And then all the other state that doesn't have number, the program has a security feature where if the cases is lower than 16, it will not give you the actual number to protect the patient. So why this is very important? I think it's very important because we can direct the resources to the states that have the highest number of cases. And we can study their population more in depth. And that's also will be helpful if we are trying to develop a collaborative type of study between the institution. These are the state will be looking for collaborative people to talk to help us to address issues for a patient who's living with this disease in that state. So I think it's very helpful to understand this distribution, and then you start looking for those patient and collaborative scientists or clinician that you can work with to address this disease more. Now, after that, we look into the prevalence, which is the number of the patient who is living with a disease at specific point of time. And then when we look to the prevalence percentage over the 17 years up to the beginning of the 2018, you can see here is the prevalence percentage. But when we calculate it from the standard population of the United States, we're able to estimate that there is around 190 patients who were alive at the beginning of 2018. So it's a quite number of patients that need to have treatment and they need to be addressed. And if we remember that this disease is very rare and we are missing some patient, maybe the number is even bigger. So those are the number of the patient who were estimated to be alive by the beginning of 2018. After that, we look into the cancer-related death, a death that's being contributed only to the manic P compared to the other type of cancer. Now, if the curve is moving down, that's mean there is a worse survival. And if the curve is up, that's mean a better survival. And you can see that the manic P, the mixed pancreatic Acinar neuroendocrine carcinoma, it's actually quite in the middle. So what's worse than that? We found that pancreatic ductal adenocarcinoma is worse. Pancreatic adenosquamous carcinoma is worse. And then the pancreatic acinar carcinoma is worse than the manic, but the manic is worse than both type of neuroendocrine, which is the neuroendocrine tumor and the neuroendocrine carcinoma. This may have some limitation because the data is quite few. It's a small, relatively small sample size, but still, it could tease out something about the cancer-specific survival, and it can show that this is one of the disease that have a poor survival that need to be addressed. So here is the median cancer-specific survival, which is around 29 months. Now, after we finish building the foundation about this disease in the United States, knowing the number of the new cases, the number of the patient who's alive with this disease, and also the cancer-specific survival, we dive deep to look into what's the impact of the surgery on the survival of those patients. And our aim is to see that using the same database. So we use the SEER database between the same timeline, looking to this factor. And this is the statistical test that we use to tease out the survival. So in the beginning, we identify 170 patients. And as I told you, the SEER database, it's not covering all the United States as the other database, which they are together, they're covering the United States, but the SEER database cover almost 30% of the United States population. So the number is quite low compared to the previous database that we use for the general epidemiology. So we found 170 patients, but we excluded cases that's reported of manic from the liver, gallbladder, and other side as well. And also excluded cases that doesn't have a confirmatory test, because we think that this need to be diagnosed from histological slides So excluded patient who doesn't have a confirmatory positive histology. And then we confirm, we excluded those patients as well. So we end up with 149 patients. 109 of them received surgery, and 40%, 40 patients, they didn't receive surgery. Here's the distribution or the differences between patient who received surgery and patient who didn't receive surgery. In regard to all the demographic data here, the age, sex, ethnicity, race, and grade of the tumor. And there is no difference in that demographic part. And then we look into some of the treatment data and some of the cancer-specific related factors. So there was no difference in the chemotherapy, but there was like a significant difference in the radiation. I should mention here that the SEED database, it's not robust enough to tease out questions about chemotherapy and radiation. So that's why we didn't focus on getting an actual systemic therapy differences between patient who received those systemic therapy and patient who didn't, or also the radiation, because the data is not granular enough. And actually, the database is official. They will like send you some limitation of this database, so you need to consider that. So we consider that also when we do that. So we cannot get a definitive answer of the impact of chemotherapy or radiation in regard to this data, although we found some difference. That may help us just to control it from a statistical point of view. Now we look also to the regional disease, and you can see that the patient, if they have like a distant disease, they may not receive surgery, and that's quite obvious, and also similar to the metastatic manic P tumor. The primary site is most common in the head and the pancreas, and if it's in the head, they would receive surgery. And then there is no difference in the tumor size between patient who received surgery or not received surgery. But the tumor stage, actually, it's quite different. So if the stage is quite higher, they will less receiving surgery, and they will not receive any surgery. So that's just in the beginning. Then we'll look into the survival difference, and it's also similar. So the lower the curve is, the worse the survival. So we were able to tell that patient who receive surgery, they actually have a better survival curve than patient who didn't receive surgery. And this is was significant. But we need to interpret this with cautious also, because the sample size is small as well, and also related to other factors as well. So surgery may have some impact on improving the survival of those patients. But we take that and we study all the other factors to see if they are impacting the survival as well. And you can see that the age is a risky factor here. Increase in the age may worsen the survival. The race is a little bit like significant, but we compare white and non-white, but the number of the patient within the two groups is quite small. And then the grade of the tumor, the higher the grade of the tumor, the worse the survival. So this is when we look to each factor in a separate way. The sex is trending toward being, if the patient is female, they may have better survival, but it's not statistically significant. Now the surgery is significant, as I just showed you in the previous figure, and the metastatic and the positive lymph node, and the higher the state, they worsen the survival of the patient. Now, this is here when we compare all of them, what we call it is a multivariate analysis. And the idea is to put all the significant factors that you find and significant from the separate analysis, and then that will control for these factors, and that will tell you which one is actually more statistically significant, just to provide a more confidence into your findings. So what we found from that the grade is highly a risk factor. So the higher the grade, still the worse the survival, especially for grade 3. There is no grade 4. And grade 4 is actually like a metastatic disease, so there is no grade 4 here. And then the metastasis is actually also worsening the survival of the patient. but the surgery changed to be not significant in the multivariate analysis model. So that's why we need to be a little bit cautious about that thing. And that will need further type of studies. So this is in regard to the questions that I have studied with the epidemiology and the impact of the surgery on the survival. The other two aim, it may be better to be discussed in a different time, where we characterize all the tumor that we have in the mice. And we actually did a very nice job comparing it to other model that we have in the lab. So we compared it to a different Acinar tumor, and then we compare it also to a different neuroendocrine tumor. Hopefully that we can find like main difference that will tell us like if there is any similarities between those diseases, or this may be a separate entity of tumor that need to be treated separately in a different way. And then the therapeutic study that we did in the mice, it's actually we use one model, so it might not be representative, but maybe in the future I can show this data to convince you that there is some drugs that may be working. But just to save the time today, we'll not cover this. So I will jump into some of the future direction. I think one of the most important thing after we just covered the epidemiology of the manic bee throughout the United States is to be able to understand the natural history of the disease. And that's actually will need some collaborative effort between investigator and different institute to be able to be more in touch with those patients and trying to understand their quality of life issue and how they live. Also to know more about their symptoms, which may be a little bit different from other type of pancreatic tumors as well. And then follow them for a long, long time. And that may give us some information about the natural history of this manic bee diseases. The other thing is, I think, also to do to tease out the impact of the systemic therapy response, the chemotherapy impact of the manic bee progression. I think this is a very important question because, as I told you previously, most of the patient right now, they will just receive like they will just be dealt with in a separate way as a just case report. So they will be treated quite differently between institutions. But it may be helpful if we can aggregate this data all together and see which one is more helpful in tackling this disease than other. And I think also a third aim will be to look into the epidemiology throughout the world and actually started to collaborate with an institution for health metric and evaluation. This institution actually produced the burden of the disease report every year throughout the world. So I started a collaboration with them, hopefully that we can build the epidemiology for all over the world. I think the second maybe future direction of this is to understand more about the therapeutic by doing testing in the lab. And we were lucky enough to generate this mouse model from the actual patient tumor. So right now we have this model in the lab to test many type of chemotherapy that may, we think that may have effect on this tumor. And right now we have two type actually of mixed neuroendocrine carcinoma. And we can compare them to the other type of carcinomas that we have in the lab. We also were able to generate like a cell line from this to do a bench studies as well. That's maybe also more quicker than the animal study. But the idea is also to do a full molecular characterization. And that's what I've been working on right now for the last year, trying to understand the molecular basis differences and similarities with other type of pancreatic cancers to find some targets that may be treatable with some targeted therapy. By this, I hope by the end of this presentation, I was able to clarify this blurred picture about manic bee. And I hope it right now it will become more clear picture about this disease a little bit, hopefully, and generate more questions that we can tackle through through more research and through more collaboration between all of us. And when I say all of us, I mean like first patient, and then scientists and clinicians. If we work all together, I think we'll be able to help tackling this disease and improve the quality of life of patient who's living with this disease, and maybe in the future, we'll just find a cure for this disease. So at the end, I would like to thank people who helped me throughout my master journey to understand more about the mixed acinar neuroendocrine carcinoma of the pancreas. My main mentor, Dr. Mark Trudy, he is a surgical oncologist here at Mayo Clinic, and he will be more than helpful to discuss surgical approach for pancreatic cancer patient. Dr. Yin, a statistician and a very smart statistician who helped me actually figure out and generate all these nice figures for the epidemiology data that we have done. Dr. Half Dennerson, and I'm very sure that most of you here, the audience, you know him as a world-renowned figure in the neuroendocrine tumor and carcinoma world, and also the rare tumor world. He's been a tremendous source of help for me throughout my journey and pushing me to find more answers about this tumor. Dr. Randall Graham, a pathologist and a smart pathologist who helped me navigate all the diagnostic issue for this tumor and helped me find some markers for these tumors as well. And then Dr. Wenwima and Dr. Mahiba, both of them are medical oncologists who helped me a lot on identifying some chemotherapy and guiding my journey to find some answer about those chemotherapy impact on the models that we have in the lab. Also, I will not forget to thank also Dr. Smoot, who is doing most of my bench studies here also within his lab, and he's being a quite tremendous source to find some answer on a daily basis in the lab as well. And we are working under the direct guidance of Dr. Gors, the Dean of the Research here at Mayo Clinic. Dr. Barrett, who helped me characterize the DNA characteristics for this manic B tumor, and maybe in the future I can show you some of the data from what he had. Dr. Johnson and Dr. Wexom also helped me navigate another angle from the molecular characterization, trying to find some novel and novel targeted therapy that may give some hope for those patients. Dr. Lighting and Dr. Roberto, Dr. Yonkes, and Lynch, a graduate student with us here in the lab, working with me on a daily basis in the lab, trying to answer our question related to this tumor, other type of tumors as well. So we are working as a team, trying to find many answers for some type of cancers as well under the direct mentorship of Dr. Mark Trudy. And also, I would like also to thank my wife, who's also a pediatric cardiologist working here at the clinic, finishing her training. She's been a tremendous source of support and encouraged me throughout my journey here. By this, I will open the floor for more questions, and thank you very much for listening.
Thank you so much, Amro. That was a wonderful presentation. I really enjoyed it. You had great graphics, and I have learned more about Mannix than I've ever known before, so I really appreciate that. I'm going to open the floor for questions now for everyone. I am going to start us off with a question in the chat from Simon. And then after that, I encourage people to unmute and ask a question, or you can also ask a question in the chat. But okay, to start us off, Simon has a question in the chat, and he's asking, how plastic are pancreatic acinar and/or neuroendocrine cells? Could you give me some more details about the phylogenesis of amphicrine cells? For example, could you elaborate on potential transdifferentiation between acinar cells and neuroendocrine cells? Does treatment impact the appearance of this subtype? He is also wondering, how closely are manic Ps related to PACCs? For example, biologically, behavior, symptoms, and what are the implications of the mixed background for therapy selection in patients?
Great. Thank you very much, Simon. This is actually a fantastic question. And those are actually the target that we are just studying in my last year and throughout this year as well, trying to find more about the molecular basis of this tumor. So in regard to the plasticity of this tumor, we don't know yet. We don't know the actual answer for this. If it's just there is a cellular population in the pancreas that we are not aware about, that's actually generating this tumor. Or maybe, as you just mentioned, maybe it's a transdifferentiation issue. Maybe the neuroendocrine cells trying to, there is some genetic mutation that help them to differentiate from neuroendocrine and go into the acinar component. And maybe they stuck in between. They're trying to go there, so they go back and then to a more progenitor form and go to the acinar component. Or maybe they're stuck there forever, and that's why we found some of the cells that has both markers on them as well. So this is actually what we are studying right now. So we're doing many type of genetic testing, trying to tease this question. And we also have the help of Dr. Randall Graham, the pathologist, who's actually helped us look at those cells to see if there is any differences between other type of tumor. Not only that, but also after treatment. So what happened after treatment? Is it the cells just died and we don't find the tumor? Or maybe when we're treating with some type of treatment, we're actually pushing the cells to differentiate into one direction or more. And that's actually what we are doing just like right now. Last week, I just gave him, Dr. Randall Graham, more slide to look at after we did some treatment study on the mice that we have here in the lab. So hopefully maybe in the coming few months, we'll have some idea if we need to dive even more deep into that direction. Now, how close is manic B to the pancreatic acinar cellular carcinoma? We have also, as I said, like we have those type of tumors. So we have the manic B tumor, we have the acinar cellular carcinoma, and we have the neuroendocrine carcinoma here in the lab, and we send them for many type of molecular characterization, and with the help of all the collaborators that we're working on with, I hope we can find some clear cutoff point, if any, or maybe there is no clear cutoff point, and maybe they are similar, so we don't know yet. But from the data that we have up to today, we think it's different. We think it's different, but this is an interesting question as well, because some of the actually clinician may rely on this, as I just mentioned earlier in my presentation, that if they found more acinar cells in this manic B slides, they may tend to treat them with standard of care therapy for acinar carcinoma. So we are trying to find answers so we can help them find better treatment for those patients. Nice questions.
Thanks a lot. Very interesting. So thanks.
Thank you.
Do we have any other questions before I ask one? Yeah.
Yes, I do have a question. A very nice presentation and very nice data that you presented. Thank you so much. And I completely agree. This is an unmet need. And I like the fact that you're thinking about doing or studying these patients longitudinally to understand more about this. And in that case, I'll be happy to collaborate with you, because we do see those patients here as a second opinion. But one question I do have is that in the cohort of the patient that you study, it seems that some of these patients may benefit from surgery. And in that case, is that the ones that have localized disease, or do in like neuroendocrine tumors, do you do the bulking surgery when they got to the liver? And after the surgery is done, do you give any adjuvant like FOLFIRINOX, like modified FOLFIRINOX in those situations? So, and also sometimes when I see those patients and I review with the pathology, sometimes I need to see what is the maximum component of what is this acinar, or whether it's neuroendocrine tumor, because that can sometimes guide me what is the treatment. If we see that the majority of the content, when we look at the pathology, is a neuroendocrine carcinoma, we know how to treat that. The same with the mixed acinar, we know how to treat that, and usually one of the treatment is with modified FOLFIRINOX. But I was just wondering what are your thoughts about that?
Great question, and thank you very much, Dr. Rivero. Actually, I'm very happy to collaborate with you or anyone who is interested to work. This will not be a great effort to answer all the questions without doing like a teamwork thing. So thank you for that offer. In regard to the cohort that I just said, as you mentioned, we used a national database, the SEER database. So that database may not be robust enough to answer all the questions. So we don't know if these surgeries are actually debulking surgery or what's happened after that. Are they just receiving a new an adjuvant therapy after the surgery or not? So that's why right now I'm actually writing a protocol to query the SEER database that's linked to the Medicare database. I think it had more robust data to answer some questions about the chemotherapy. I think that may be able to give us like at least a foundation on which chemotherapy is more effective at which time, neoadjuvant or adjuvant. So I think the database may not be robust enough to answer that question. But also maybe if we develop a collaboration between multiple institutions in the United States, actually, it may become even more robust than the SEER Medicare database, linked databases, because we'll be able to even tease more factors and get to look into more factors. And in regard of that, it actually went to the Mayo Clinic Cancer Center to query about cases that have been seen in the clinic since the inception of the Mayo Clinic Cancer Center. So sometime in the 1990s. In the beginning, actually, they just sent me, they say like, we just saw 6 patients. And I couldn't believe like that we only just saw 6 patients, although I know that this is a very rare disease. So I went back and I actually looked more in depth into the pathology reports. And from the pathology reports, it's actually become more helpful because you can see the stains, you can tease out it's manic. But when it came back to some of the clinician, when they see some of the population, dominant population, according to the recommendation from the pathologist, they may just call it and code it as Acinar or neuroendocrine. So maybe in the clinical record, it will be called that way. But I was able to find like 30 patients. It's not a big number, but it's quite different than 6. I mean, like if we look to, if we develop a collaboration with other institution, I mean, like we could find like some hundreds patients, and then we can dig deep into about their chemical chemotherapy data, radiation data, surgery data in more granular way. And that's what I hopeful to do in the coming years.
Thank you so much.
Thank you.
Okay, do we have any other questions?
I have a question, but I can also Google. This is a very naive question, but you know, we have opportunity to have a lot of MDs and surgeons. What is actually the difference between adenocarcinoma and acinar cell carcinoma? Because they both originate from acinar cells, yes? And it is like opposite to neuroendocrine cancer, which originates from islet cells. If anyone can, you know, explain this, this will be great.
I'll just start, but I didn't like study those cancer in depth, but my understanding is yes, the ductal adenocarcinoma is quite similar on some of the hypotheses that it's actually generated from the acinar cells. But just frankly, it's more ductal cells than acinar cells, and that's why we call it ductal adenocarcinoma. And then the neuroendocrine, it's quite different. Maybe other clinician could help me with the answer of this.
Yes, because I saw that you have in Incidence those 2 groups, yes?
Yes, I do have them as a comparison just to tease out how quite different is the number of the new cases of the mixed acinar neuroendocrine compared to the other type of tumors that we know some information about. So that this comparative descriptive analysis is quite helpful actually to just show the bigger picture.
Thank you.
Thank you.
Wonderful.
I think I can make a comment. I don't know if Dr. Abdelrahman may
Yeah, go ahead.
agree with that, and maybe anybody here, but it seems even though in regards to the question that Dr. Jaskula was answered is that in terms of the origin, it seems that pancreatic adenocarcinoma and pancreatic ACC, and that's how we call it, may arise from the same cell of origin. However, it seems that the pancreatic ACC in terms of biology and behavior is not as aggressive pancreatic adenocarcinoma. Moreover, the difference sometimes with pancreatic adenocarcinoma that has very specific tumor markers seems that these pancreatic ACCs may also produce like FFP, for example, and it's something that we may follow in those patients. And I don't know if you may agree with that. Dr. Abdelrahman. But yes, in terms of biology, even though they may arise from the same cell of origin, but in terms of biology, maybe a little bit different in how they also present under the microscope, of whether they produce other tumor markers different from the pancreatic adenocarcinoma. But of course, it's different from the pancreatic or neuroendocrine carcinomas in that aspect. I don't know if that answered your question, and I hope I don't know if Dr. Abdelrahman.
Yes, thank you. I think it's more clear because you know, I was a little bit surprised why this group is kind of divided, because they both originate from acinar cells, right?
Right.
Thank you.
Wonderful. I encourage people keep asking questions. I did want to bring up a question that was submitted by Brent in advance of today. And I opened this question to our speaker, Amro, alongside any other clinicians on the talk as well. I'm going to put this question in the chat so you guys can read along with me. And so this is Brent's question. And he's asking that he's recently had cytoreductive surgery and is currently NED, no evidence of disease. He received mixed input on continuing lanreotide, which was very effective at keeping his mets in check and actually killed 50% of the biggest one over his 3 years of treatment so far. From your experience or any physician's experience on this call, would staying on lanreotide be effective in providing a longer progression-free period? Or would it start to lose its effectiveness and wait, and he should wait until new mets appear? So if anyone wants to comment on Brent's question, that would be great.
Yeah, I will defer it also to the clinician who had license to practice that they just mentioned at the beginning of this. And that's maybe the most appropriate way of answering this question.
Yes, I can. I mean, I assume we're talking about neuroendocrine tumor, maybe. Yes, not.
Yes, Brett.
Okay.
And I'll clarify, this is primary is in was in the ileum.
Okay, great. I mean, just if I may say this, so the function of the lanreotide or somatostatin agonist, and we know in terms of the somatostatin agonist, we either have lanreotide or we have sandostatin or octreotide. So it has two functions. One is to control hormone excess, and the second function is to slow down the growth of the tumor. Now, if we have a patient that has a neuroendocrine tumor that is producing excess of hormones, even though after surgery we don't see any evidence of disease, but it's still quite symptomatic and the levels of hormone have still elevated, I will definitely continue the lanreotide. Now, if there is no evidence of disease, there are not symptoms related to the hormone excess, and this is just my own personal practice, I don't necessarily continue lanreotide because in my mind, in order for me to make sure if the lanreotide is working, I would like to see something that I can follow in scans. And if I don't see anything that I can follow in scans, I don't know if lanreotide may be working or not. And that's just my personal preference. I know that some other NET experts, they just want to continue just because there is no data, even after surgery, we don't know if by continuing lanreotide, whether that will help to slow down the progression of disease or whether it can also, decrease the risk of recurrence. We still don't know that answer to that question. So that's the reason why sometimes it depends. Some NET experts may recommend continue the sandostatin. I personally say, well, if there is nothing I can follow in scans, I just kind of like to watch it. That being said, now if there is a tumor that has produced a hormone excess and we still has evidence of hormone excess related to the tumor, then yes, I will continue the lanreotide.
I see. Okay. Yeah, this was distant metastasis. It was grade 1, less than 1%, well differentiated, and the side effects of lanreotide appear to be worse than any symptoms that I'm getting. In fact, there's absolutely no symptoms, non-functional.
Right. Yes, and I can understand because we see these lanreotires and the stat like inhibit any hormone production, and sometimes in the setting of not having hormone access. And I think, let me see if I saw Dr. Augusto Salgado, who is an endocrinologist, maybe she can have an opinion about this. But one of the things is that it can also have some side effects. And one of the things that can also cause diarrhea. And how do we control the diarrhea in those situations? Because the diarrhea associated with this type of medications is a kind of malabsorptive diarrhea. So in those situations, we recommend Creon to help for that. So because it also inhibits some hormones as well in the pancreas by giving those medications. But it's something that we definitely need to discuss, with your doctor and understand more about the side effects and also understand the risk of the benefits in the absence of any symptoms. I don't know if that makes sense.
Oh, yeah, it does. And I've been on Creon because of the malabsorption, and it's very diet limiting even with the Creon.
I know.
Thank you.
Wonderful. So we've got 1 minute, and then we'll hit our hour mark. So I will go ahead and wind things down. And
Mayo Clinic is committed to creating
big thank you
for our patients
to our
and
speaker,
staff.
Amro. And thank you all for attending. It was so wonderful to see everyone here. Again, our next meeting will be next month. It's the last Thursday of the month. So stay on Twitter, check your email. We'll be sending out notifications. And we hope to see everyone there. And so again, thank you to our speaker. Thank you, Selena, and thank you to our ambassadors and all of our attendees for joining us today.
Thank you very much. Thank you for everyone.
Thank you.
Thank you so
Alright,
much.
Thank you.
Thanks a lot.
I'll see you next month.
See you later.
Yeah,
That's correct. And then I will be in touch with you, Dr.
Yep.
Alderman.
for sure. Please. Thank you. Thank you very much.
Thank you
Have
very
a good
much.
day,
That was great.
everyone.
You too.
Thank
Bye-bye.
you. Bye.
All right. Bye, Selena. That was wonderful.
Bye. That was amazing.
Yes. Bye-bye.
Bye.